So what about endocrine adjuvant therapy in breast cancer? At present, we have tamoxifen, aromatase inhibitors, and GnRH analogs, or the so-called ovarian function suppression. So you can do this with ovarectomy, we can do this with radiation of the ovaries, or you can do this with GnRH analogs. And in the future, we may have the addition of mTOR inhibitors or CDK4/6 inhibitors. There are trials investigating these two drugs in the adjuvant setting of hormone receptor positive breast cancer, and will show you at the end of this adjuvant endocrine session some of these trials. So let's go to the endocrine therapy of the postmenopausal patients. This is a proof of principle trial of data of the early breast cancer trialist group comparing 5 years of tamoxifen versus no adjuvant endocrine treatment. More than 10,000 patients were in these data. They were estrogen receptor positive, or the estrogen receptor was unknown, and roughly a third, 30%, were not positive. And what you can see is, and I'd like to focus on the breast cancer mortality, that you have a 14-year gain of 9.2%. So roughly after 15 years, 10%, or there was a difference of 10%, roughly 10%, when you treated the patients with adjuvant 5 years of tamoxifen compared to no adjuvant endocrine treatment. So as a consequence, to improve this data, aromatase inhibitors were investigated in the adjuvant setting of hormone receptor positive breast cancer. And you can see all those trials with different trial scenarios comparing aromatase inhibitors to tamoxifen. And there was a meta-analysis of all these trials, and what you can see comparing 5 years of tamoxifen versus 5 years of aromatase inhibitor-based therapy, that the relapse rate with aromatase inhibitors decreased by 30% versus tamoxifen, only while on treatment. Breast cancer mortality with an aromatase inhibitor decreased by 15% versus tamoxifen. Breast cancer mortality with an aromatase inhibitor decreased by 40% versus no adjuvant endocrine therapy. Regarding the side effects, we've seen that the endometrial cancer rate with aromatase inhibitors was lower compared with tamoxifen, 0.4% versus 1.2%. And the bone fracture rate was increased with aromatase inhibitors compared to tamoxifen, 8.2% versus 5.5%. So when you look here at this graph, you can see the delta, so which is actually the real difference between tamoxifen and aromatase inhibitors. When you compare 5 years of tamoxifen with 5 years of aromatase inhibitors, the 10-year difference was 3.6% regarding disease-free survival, and it was 2.1% regarding the breast cancer mortality. When you compare 5 years of tamoxifen with 5 years of endocrine treatment, starting with tamoxifen and switching to an aromatase inhibitor, the delta is 2% in favor of the aromatase inhibitor-based treatment regarding the disease-free survival, and it was 1.5% regarding the breast cancer mortality. When you compare 5 years of endocrine treatment starting with tamoxifen followed by an AE versus 5 years of an aromatase inhibitor, you can see that the delta is not very large anymore, only 0.7% regarding the disease-free survival and 1.1% regarding the breast cancer mortality, and this was actually not statistically significant. So we have differences in favor of aromatase inhibitors compared to tamoxifen, but you can see the differences are modest, but they are still there and they are significant. So what kind of patients may benefit in particular from using an aromatase inhibitor compared to tamoxifen? And it was retrospective analysis of the big 198 trial, which was comparing aromatase inhibitors 5 years versus tamoxifen 5 years, or tamoxifen followed by aromatase inhibitor, or aromatase inhibitor followed by tamoxifen, in total for 5 years. And what you can see is that in particular in the lobular invasive subtype, the aromatase inhibitor was particularly effective compared to tamoxifen, and it was also in the luminal bee-like tumors. So luminal bee-like tumors and lobular invasive tumors had the best benefit in this retrospective analysis of the Big 198 trial, had the biggest effect, had the biggest benefit from the aromatase inhibitor letrozole compared to tamoxifen. Those two drugs have different side effect profiles. With tamoxifen you have more thrombosis, more embolic events, more cardiovascular disease, more endometrial cancers, more endometrial disorders, more gynecological symptoms in terms of discharge, and more vasomotor symptoms. With aromatase inhibitors you have more arthralgias and myalgias, you have more osteoporosis, more bone fractures, and you also have more gynecological symptoms in terms of vaginal dryness and dyspareunia. So what should we do now in treating patients with endocrine treatment in postmenopausal patients? Certain women are definitely at high risk of early recurrence based on advanced stage, like large tumor or multiple nodes, like HER2-positive disease, like negative progesterone receptor, or a high proliferation index measured by Ki-67. These patients should get an aromatase inhibitor upfront. Or patients with lobular invasive subtypes, they should also get an aromatase inhibitor upfront. And these patients should actually be considered for initial therapy with an AI. For patients not at high risk of early relapse, either upfront AI or tamoxifen or AI remain reasonable. For the women at very low risk of recurrence, a clinical meaningful difference between AI and TAM in the first 5 years is quite unlikely. So low-risk patients should receive the best tolerated regimen that will maximize adherence and minimize impact on quality of life health status. And it's actually not only the low-risk patients, it's also the other patients. You should take this into consideration, but if you give the best drug but the patient does not tolerate it, it doesn't help at all because the patient will not adhere to this drug. So this is drug adherence is also a very important point. So what about the premenopausal patients, endocrine therapy in premenopausal patients? This is also data from the early breast cancer trialist group, which was looking at patients having had an ovarian ablation versus no endocrine treatment. Also, many patients were enrolled in this trial, 7,600. Estrogen receptor was positive or unknown. It was actually unknown in almost half of the patients. And 61% were node positive. And you can see there's a difference between the two curves. They are separating. It was in favor of ovarian ablation, and there was actually a 15-year gain of 4.3% in favor of ovarian ablation or suppression compared to the control in recurrence, and there was a 3.2% 15-year gain comparing breast cancer mortality. So what we also know that tamoxifen is not only working in the postmenopausal patients, and you can see here that tamoxifen is also working in the premenopausal patient. This is also data from the early breast cancer trialist group, and you can see that the recurrence was reduced by 54% in those with age below 40 and by 41% in those age 40 to 49. And the same picture you can see regarding the mortality. It was reduced by 52% in those below age 40 and 22% in those with having age 40 to 49. So tamoxifen is working not only in the postmenopausal patient, it's also working in the premenopausal patients. What about ovarian function suppression in combination with an aromatase inhibitor or with tamoxifen? This is the ABCSG12 trial, which was comparing 3 years of GnRH analog, goserelin, in combination with tamoxifen or in combination with an aromatase inhibitor, anastrozole, either in combination with a bisphosphonate or without bisphosphonate. And what you can see is when we only focus not on the bisphosphonate question but on the endocrine treatment question, like comparing tamoxifen with anastrozole, you can see that there is actually no difference. The curves are superimposing and there is no difference between anastrozole and tamoxifen. But when you look at the same trial and the update which has been published in the Lancet Oncology in 2011, there was actually a difference in overall survival, but it was not in favor for the aromatase inhibitor anastrozole. It was actually in favor for tamoxifen, which is the blue curve. So this was a significantly difference in favor of tamoxifen. So overall survival was actually worse with anastrozole compared to tamoxifen in this trial of the Austrian breast cancer study group. For this reason, the data of the text and of the soft trial were eagerly awaited, and they were actually reported and published recently. And let me shortly focus on the trial design of the text and soft trial. The text trial was comparing ovarian function suppression plus tamoxifen over 5 years compared to ovarian function suppression plus exemestane, the aromatase inhibitor exemestane, also both given over 5 years. The soft trial was a 3-arm trial, and it was comparing ovarian function suppression plus tamoxifen for 5 years versus ovarian function suppression plus aromatase inhibitor exemestane for 5 years, and interestingly only tamoxifen given for 5 years. The important point is that in the text trial it was the decision of the investigator to give also adjuvant chemotherapy to the patients, and chemotherapy was actually, or ovarian function suppression was actually started together with the chemotherapy, and later on tamoxifen or exemestane was added after chemotherapy was stopped. In the soft trial, first chemotherapy was given and then ovarian function suppression was started in those patients which were still premenopausal after chemotherapy or became again premenopausal up to 8 months after chemotherapy. And there was a joint analysis of the text and of the soft trial, only looking at those two groups, ovarian function suppression plus tamoxifen versus exemestane, and in total 4,690 patients were enrolled. And what we can see is there was a difference in favor of the aromatase inhibitor compared to tamoxifen with regard to disease-free survival, breast cancer-free interval, distance disease-free survival. You see here the hazard ratios and you see here the p-values, but there was no difference in overall survival. You can see here the hazard ratio of 1.14 and the p-value of 0.37 after median follow-up of 4.7 years. When we look at the breast cancer-free interval, the real difference, the delta was 4% after 5 years. The distance recurrence-free interval, the delta was 1.8%. And here again, the overall survival, the delta was only below 1%. And this was actually in favor of the tamoxifen and the aromatase inhibitor patients. So there was actually a 4-point absolute improvement in 5-year freedom from breast cancer for the combination of exemestane plus ovarian function suppression. So, but the delta regarding the distance recurrence-free survival was only 1.8%, and still, or again, no significant difference in overall survival. So, what about the soft trial? And this is the data for the primary endpoint of the SOFT trial comparing tamoxifen with tamoxifen plus ovarian function suppression. And you can see there was a slightly difference between those groups, but it was not significantly different with a p-value of 0.10. So when we look at the trial population of the SOFT trial, we can see that roughly half of the patients had no chemotherapy and half of the patients had chemotherapy. And there was actually a difference in the characteristics of these patients. Patients having no chemotherapy were usually not node positive, had mostly tumors below 2 centimeters, and many of the tumors were grade 1 and only very few were grade 3. And the pattern was totally different in those having prior chemotherapy because the investigators were clever. They were giving chemotherapy only to those having a higher risk, like more node positive disease, bigger tumors, and more grade 3 tumors. When we look at the primary endpoint, disease-free survival, also at the primary endpoint, breast cancer-free interval and distant relapse-free survival, and we are looking at the no chemotherapy arm, so the lowest population, you can see there is actually not a big difference between the 3 treatment arms, either in breast cancer-free interval nor in disease relapse-free survival. What we can say is these patients are extremely doing well. I mean, you cannot top a distant relapse-free survival of 98.6% after roughly 5 years. But when we look at the patients who have had prior chemotherapy, so this is the group which had a higher risk, the data are not as good as for the low-risk patients. This is quite obvious, and you can see a bigger difference between the group. So the absolute improvement in the 5-year breast cancer-free interval was 4.5% for giving ovarian function suppression plus tamoxifen versus tamoxifen, and it was 7.7% for exemestane plus ovarian function suppression versus tamoxifen alone. And the 5-year distance recurrence-free interval there was a difference of 4% in favor of OFS plus exemestane versus tamoxifen alone. And you can see the curves up in the graph. The biggest difference between the 3 groups you could see in the women which were very young, below 35 years, which had mostly received chemotherapy. So this is the patients very young with probably a very high risk of relapse. And there was the biggest difference. You can see a delta for OFS plus tamoxifen compared to tamoxifen of 11.2% and a delta of 15.7% for tamoxifen compared to exemestane plus ovarian function suppression. But we have to say this was a subset analysis. Retrospectively, it was a kind of exploratory analysis, so it was not prospectively planned, and this is the caveats of this data. But the more of therapy has a price. So with ovarian function suppression, we have more menopausal symptoms, we have more sexual disorders, we have more joint pain, more depression, more osteoporosis. Endocrine differences are less pronounced after 2 years, and the endocrine toxicity changes less in women which had prior chemotherapy, which were actually most of the younger patients. The adherence was not so good. 15% stopped the ovarian function suppression by 2 years and 22%. So every 5th patient stopped it by 3 years. So when we summarize this data in premenopausal patients, tamoxifen and OFS significantly reduce breast cancer mortality in premenopausal patients by 39 to 24%. And 23% respectively compared to no treatment. Tamoxifen alone for 5 to 10 years is still a valid option and is sufficient for low-risk women. we should consider the use of ovarian function suppression plus tamoxifen or plus an aromatase inhibitor for high-risk women, like women who remain premenopausal after chemotherapy, those who are having very big tumors or multiple positive nodes, and those which are very young, like age below 35 years. The treatment duration of tamoxifen is 5 years. The optimal duration of LHRH analogs is not clearly defined and varies from 2 to 5 years. The long-term follow-up of the soft and text trial is important for evaluation of long-term toxicity versus long-term benefit of adding OFS to tamoxifen or to an aromatase inhibitor. So what about treatment duration of endocrine treatment? And this issue came up when we look to the recurrence rates over time by hormones or receptor status. And this is quite an old graph, but it's still very useful and interesting. And what you can see here when you look at the recurrence rate over time, the peak of the hormone receptor positive group, which are the blue curves, is not as big as it is with the hormone receptor negative patients in the first 3 years. But when you look for the next years, it is still maintaining over many, many years. So patients with a hormone receptor positive tumor do not have this big hump in the first 3 years, but they maintain their relapse rate very consistently over many, many years, which brings up the question if it may be better to treat more than 5 years with endocrine treatment. And we have some trials which are investigating this issue. There's a very old trial which has been published in 1996 comparing 2 years versus 5 years of adjuvant tamoxifen for postmenopausal early-stage breast cancer patients. It was a big trial with 3,500 patients. What you can see is that 5 years, which is the dotted line, was significantly better in event-free survival and also with regard to overall survival, which was also with a p-value of 0.03 significant. So as a next consequence, 5 years, which was the standard for many years, was compared with 10 years of endocrine treatment. This was the MA70 trial, one of the trials who does this comparison. The treatment was 5 years of tamoxifen, and then patients were randomized to 5 years of an aromatase inhibitor or 5 years of a placebo. So it was 5 years versus 10 years, starting with 5 years of tamoxifen, then switching to 5 years of an aromatase inhibitor. And what you can see is that there was an absolute difference of almost 5% for the whole study population with regard to disease-free survival in favor of treating 10 years versus 5 years. The treatment effect was more pronounced in the node-positive patients, which also had a significant overall survival benefit with 10 years of endocrine treatment compared to 5 years of endocrine treatment. There were other trials comparing 5 years of tamoxifen with 10 years of tamoxifen. So patients after 5 years of tamoxifen were randomized to 5 years of tamoxifen or to stop of tamoxifen. These were the ATOM and the ATLAS trial. And the relapse rate was actually, the relative risk was 0.85 in favor of the longer treatment. The absolute difference was 4% for the ATOM trial and 3.7% for the ATLAS trial. And it was also in favor for the longer treatment. When you look at the breast cancer mortality, the absolute difference was 2.2% for the ATOM trial and was 2.8% for the ATLAS trial. A trial which has been recently shown at this year's ASCO was the re-randomization of the MA7 trial. I just showed you the data of the MA7 trial, and there was actually a re-randomization. So patients after 5 years of tamoxifen, after 5 years of letrozole, were randomized to 5 more years of letrozole or to 5 years of a placebo. So in total, this was 15 years endocrine treatment for part of the patients. And it was 10 years of an aromatase inhibitor. In a second part of the MA7 re-randomization design, patients which had treatment with 5 years of an aromatase inhibitor were randomized to 5 years of letrozole and 5 years of a placebo. 70% of the patients of the MA7R trial had tamoxifen, so 70%, the majority of the patients were coming from this group. 54% were node negative and almost 60% had adjuvant chemotherapy. So what were the data? The data were, and you can see here, there was a difference in favor of treating with 5 years of aromatase inhibitor after 5 years of tamoxifen followed by 5 years of an AI, or after 5 years of an AI. The hazard ratio was 0.66 and the absolute values were 95% for letrozole versus 91% for the placebo. So there was a 34% reduction in recurrences. When you look which kind of recurrences were reduced, so it was mainly the new contralateral breast cancer. It was a little bit of distance recurrences. It was a little bit of local recurrences. It was a little bit of bone recurrences, but the majority were the distance over the new contralateral breast cancers. So this may be also the reason that there was no significant difference in overall survival with a hazard ratio of 0.97. So what we can conclude from this trial, we have now data for 15 years of endocrine treatment, and we have data for 10 years treating with an aromatase inhibitor. And there was a difference with regard to disease-free survival, but there was not a difference with regard to overall survival. And maybe the most pronounced effect was a kind of prophylactic, preventive effect regarding new contralateral breast cancers. So this is not a kind of characterization of the patients who were entering this trial, and you can see that either in the placebo trial and in the letrozole treated group, 15 to 60% had prior fractures prior to randomization, 20% had osteoporosis, and also half of the patients already had bisphosphonates. Most of the patients had before randomization calcium and vitamin D intake. So what about new drugs as adjuvant systemic therapy? This is the PALACE study, which is actually investigating the CD4K6 inhibitor palbociclib. This is a big trial. 4,600 patients will be recruited, will be enrolled in this trial. They are all hormone receptor positive, are HER2 negative, have a stage 3 or stage 2B or stage 2A. And they will be randomized to endocrine therapy plus palbociclib given for 2 years, or to endocrine therapy alone, which is currently the standard of treatment. After surgery, radiotherapy, and adjuvant or neoadjuvant systemic chemotherapy. We have 2 other trials which are evaluating the mTOR inhibitor everolimus in the adjuvant setting. One is an American trial, the NSABP SWOG trial. Also big trial, 3,400 patients will be randomized. Hormone receptor positive, HER2 negative, pre- and postmenopausal patients. 0 to 3 lymph nodes, or a recurrence score which is greater than 25 or more than 3 involved lymph nodes. So if there are 0 to 3 involved lymph nodes, the recurrence score must be bigger than 25, or patients had 4 or more involved lymph nodes, then the recurrence score doesn't matter. Primary endpoint is invasive disease-free survival. Everolimus will be added to endocrine therapy. Everolimus will be given over 1 year, or the placebo will be given over 1 year. And the second adjuvant trial with everolimus is a French trial from Unicancer. 2,000 patients will be enrolled, hormone receptor positive, HER2 negative, pre and postmenopausal. And there is a big difference to the other trial. Patients will be randomized after 2 to 3 years of endocrine treatment, and those who are relapse-free after this period of time will be randomized to everolimus 10 milligram per day for 2 years, or to a placebo for 2 years, giving in combination with an aromatase inhibitor or tamoxifen.